now I'll talk to you about something completely different. We're moving into the urinary system, and more specifically talk about an entity that's called by some bladder pain syndrome and by others interstitial cystitis. And before I go on, I'd like to define two key acronyms which I will use during this entire presentation. First is lower urinary tract symptoms, more detail about them in a minute, and bladder pain syndrome / interstitial cystitis. It's a very awkward acronym, I'm sorry, however, it reflects the current lack of international consensus. Societies in the Americas use one term, whereas the European Society for the Study of Interstitial Cystitis is suggesting to actually change the nomenclature to bladder pain syndrome. And just to define, according to the ESSIC criteria, bladder pain syndrome or interstitial cystitis is a suprapubic or pelvic pain, pressure, or discomfort that's perceived by the patient to be from the urinary bladder. And also accompanying, there needs to be at least one more symptom belonging to the lower urinary tract, and the duration of all these symptoms should be more than 6 months. To make such a diagnosis, it's important to clinically exclude all other diseases that can be originating of the pelvis or causing such pain. And it's critical to perform a cystoscopy. That's another difference. In the, for example, states and Canada, cystoscopy is not required. And pain, of course, is a more subjective, so clinician has to define it according to the patient interview. And this is the purpose of our studies, to answer these 4 questions you see here. In general, we're trying to see if there's any correlations between the patient's symptoms and the cystoscopic grade of the disease, between symptoms and the volume of the bladder, and whether the grade is related to the patient's bladder volume and patient's age. And what we've done is analyze retrospectively the files of 447 women who have been treated for bladder pain syndrome, interstitial cystitis in Halifax, Nova Scotia. You see a very wide range of age, from 16 to 91. And we've recorded the findings according to the European criteria, which you saw earlier. And we've devised our own systematic interview to categorize the severity of the symptoms. And statistics, we've said, as usual, the P is at less than 500ths. And this is the sort of scheme we've used for to categorize the symptoms. We've grouped the symptoms first into the abnormal storage symptoms and the voiding pattern symptoms. The scale 0, 1 to 3 is used consistently in all patients and all symptoms. And quick word about cystoscopy itself. We've used a standard protocol and with general anesthesia and hydrodistinction, and all the findings were categorized according to the criteria set forth by ESSIC. And this is a summary of what the results look like, at least numbers-wise. As you see, the dominating symptom is suprapubic pain and urinary frequency. And automatically that begs the question, is this statistically significant? More about it in a minute. And here is a summary of the cystoscopic findings. As you see, the majority of patients presented with grade 2, so moderate to large glomerulations of the bladder mucosa. That's almost 3/4 of our patient group. And here are some numbers. In red, I've marked the statistically significant correlations. And as you see, suprapubic pain and urinary frequency are statistically significant. These are positive correlations, meaning a patient who has a more severe cystoscopic disease will more likely experience more pain and more frequency than other patients. We have some negative correlations. Stress incontinence and urges incontinence are negatively correlated. So, and that we actually expected because these 2 symptoms are not specific to this disease. And this is just a graphic visualization of the 2 positive correlations, the urinary frequency and suprapubic pain here, and the 2 negative, the 2 types of incontinence. And with another question, we've asked ourselves whether the symptoms, once again, are related to the bladder volume. And we found that frequency, once again, but nocturia and urge incontinence are inversely related to bladder volume, meaning the patients with the smaller bladder volumes are more likely to experience urinary frequency, nocturia, and urge incontinence. And further along with the questions, cystoscopic grade is also inversely related to the bladder volume. So patients who have smaller bladders experience a more severe disease that we see on cystoscopy as higher grade changes of the mucosa. We've also looked at the average volumes of patients experiencing different type of cystoscopic grade disease, and the ANOVA test revealed that the average volumes for the grade 2 and grade 4 disease are statistically significant. And last but not least, a finding that I found very interesting is that age is actually inversely related to the severity of disease in cystoscopy. So older patients actually have less severe changes in the mucosa. They're the ones that are going to have the changes you saw on the very left, moderate changes. Whereas younger patients would have more severe changes during the duration of the same disease. So going back to the original 4 questions, the answer to all of them is yes. And of course, the symptoms of, as I mentioned, of pain and frequency are positively correlated, whereas the others are inversely correlated. So they do add up a cohesive picture. And that is what we found. Thank you very much.
Questions?
Explanation why it's inversely correlated with age?
Well, one hypothesis is that younger patients also have younger immune systems, and they're more likely to mount a larger immune response to inflammatory agents. And we are dealing with a bacterial infection in cystitis, and that's the idea we have. Although we cannot confirm this just based on these results. It will require a lot more parameters to look at, but that's the working hypothesis.
Hello, I'm Dimitris. I'm from Cardiff University, UK. Thank you very much for your presentation. Did you think of culturing any bacteria to see whether the type of bacterium influences the outcome?
Very good question. That is something that we're thinking of for the next project, simply because bacterial cultures are not required to arrive at the diagnosis. So therefore, we followed exactly what the diagnostic criteria are to establish this diagnosis, and then look at the patterns within that. But you're right, it doesn't make sense to look at whether the type of pathogen has an influence on the severity of the disease.
The cystitis, is it always bacterial infection, or are there other etiologies possible? Behind the question is that maybe you look at a very diverse group of etiologies resulting in one clinical presentation, and maybe the etiology is more important than clinical presentation.
You're right. Bacteria are not, of course, the only possible pathogen. However, they tend to be the dominant one, more frequently found, which would make even more an extensive project, because very different culturing methods would be employed and the length of time required to get the results. But you're right, viral and fungal etiologies are also noted in the literature.
Any other questions? Then we'll move on to the next.